Nëse jeni dakord të fillojmë. Është kënaqësi që sot këtu para jush, duke respektuar masat e mbrojtjes nga pandemia, të shpreh mirëseardhje profesorit Mario Zovak, ish drejtorit të qendrës klinike universitare në Vinogradska, spitalit Sestre Milosrdnice, ku profesori për vite të tëra ka ndihmuar shëndetësinë kosovare, dhe jemi shumë të lumtur që e kemi sot këtu pranë nesh të ndaj përvojat e tij dhe të shpreh të arriturat më të reja në onkologji në Kroaci, dhe të ofroj bashkëpunimin me institucionet tona pas takimit që patëm me drejtorin ekzekutiv të SHSKUK-s dhe do të kemi edhe me dekanën e Fakultetit të Mjekësisë, profesoreshën Suzana Kërliu, dhe bashkë me kjo është organizim që është bërë bashkë me drejtorin e onkologjisë dr. Ilir Kurtishën dhe dr. Ferhat Sallahun, drejtorin e kirurgjisë, në mënyrë që të ofrohet një mirëseardhje profesorit, ofrohet mundësi bashkëpunimi, trajnimi dhe shkëmbimit të përvojave. Ju uroj mirëseardhje profesorit. Welcome, Professor Zovak. Thank you for your readiness to be in Kosovo again, support our doctors and give better opportunities for Kosovar patients.
You're quite welcome.
Ti bashkangjitë mjetit unë doktor Vujarit, kjo është një inovitet, një risi sidomos në dominin e onkologjisë, do të trajtimin e disa formave të sëmundjeve malinje, të cilat janë të avancuara, por edhe ato që janë në stad fillestar, për shembull me teknika të reja të radioterapisë, si të menaxhohet një kancer i pankreasit, i cili mund të evitohet edhe intervenimi kirurgjik, po të bëhet me radioterapi të sofistikuar dhe të ketë një benefit shumë të madh për pacient. Nga përvoja e profesorit do të dëgjojmë se kanë ata raste kur pacientët në stade të avancuara, edhe ata që janë stade të hershëm, me pa operacione do të kanë rrit një mbjetesë 2-3 vjet, 4, që për të arritur atë për ditët e sodit në onkologjike është shumë e madhe. Pa me përvojën cilën dhënat që i marrim nga profesori, ne do të kemi një qasje edhe një mbasyrë më reale dhe më të mirë për një trajtim më të sofistikuar të pacientëve, edhe nëse nuk bëhet ajo në Kosovë ose në vende të tjera këtu në Ballkan, ne të ofrojmë spaku pacientit ose të orientojmë ta bëjmë atë më të mirën. Thank you very much. We appreciate so much being here with us, and we will have talks after that. We will have questions, and we will ask you about the novel therapies in radiotherapy and to see what is the best for our patients. So we hope that our cooperation will be more sophisticated next year, and will be maybe this pandemic will go on, and we'll see what's happened with us. Okay, thank you very much.
Thank you. Good morning, everyone, once more. At the beginning, I have to say that this presentation has a spice of marketing, because it's performed, that new novel technique is performed in private hospital in Zagreb. And the reason for that, of course, it's too expensive for public healthcare system. And you will be the witness, and I'm very happy that I can, as a physician, as a surgeon, to share some new ideas, some new perspectives with you. Thank you so much for hosting me here. I'm happy to be here again. 2 years ago, I was here. We started a program of cooperation between our two friendly countries, and we believe that there is a massive opportunity and development in these connections, friendships, and that we can do a lot for both of our countries. So thank you again for having me here. Quick introduction. So I am a surgeon, basically. I am teaching professor in 3 universities. I have 2-3 specializations, but my field of work mostly is surgical oncology. I'm apologizing for my English, which is far from perfect, but I'm only 60, so I have a lot of time to learn. I'm also a member of American College of Surgeons. These are my, let's say, from my history, buildings that I love much. So Tel Aviv, Madrid, London, and Slovenia, and France, of course. I'm also head of the Croatian Surgical Association for last 3 years, And I am as well, by only that fact, I am a member of European Board of Surgery in side of the organization called European Union of Medical Specialists. And the next meeting of board is going to be held in Zagreb in April. I'm at this moment head of Department of Surgery in the second largest hospital in Croatia, and I'm also founder of the society called MentorMed, which I founded 5 years ago in order to gather funds and money to send young Croatian surgeons to the centers of excellence to the world. So we did it in 5 occasions. It is expensive, but it is possible. And it's, of course, it's a must. You have to send young people to the world, otherwise they cannot learn anything. So this is something I prepared together with guys from this institution. It's called Radiochirurgia. It exists as a private hospital for the last 5 years. Impressive fact that people who are standing behind it have a lot of money, and they are funding something that is not economically approved, because there is no way that you can earn so much when you compare the price of the investment. So there is a noble touch in this, because there are people who want to give to Croatia and to surrounding countries, to the patients, new possibilities with top world, of course, technology. The idea is like this. I'm sorry to say, I'm very sad that surgery is going to die. I am a surgeon, and I'm happy to be at the end of my career, because in next decades surgery is going to vanish. This way to treat someone, to cut him with your knife, with all the pain, complications, recoveries, and everything else, is going to be history. Oncology, we are now of course discussing malignant diseases. Oncology is going to replace us, and there is no need to be sad about it. We have to be happy for our patients, of course, if they prove they are going to be good or better than us. So, cancer without surgery. I will now, let's say, show you one movie telling a little story about that private hospital, about you have to have a picture. So the text is in Croatia, so I'm going to translate it. So it took us 200 years to perfect transportation, but in order to treat cancers, there is no time to wait. We have to do something really, really fast. So these are some, let's say, aspects. This is the hospital which is on outskirts of Zagreb, let's say 10 kilometers from the center of Zagreb, in a small, let's say, village. It started 5 years ago by those group I told you about. It has, I think, only 20 beds and ICU. It has very powerful diagnostic and treatment equipment, and it's equipped with the best ORs I have ever been in my life. So this is how it's look like in real life. It's not animation. As I told Bojar yesterday, the owners of that hospital are buying us whatever we ask. So we have there all the technical possibility that you can imagine, which are available on the market today. I'm going to speed up a little bit this movie. This is Professor Palladino, one of our famous brain surgeons, who is now retired, but he works as an advisor in this hospital as a part of this multidisciplinary team. This is the way how our physicists plan radiation. This is a machine called CyberKnife, and it is sixth produced in the world, developed in Stanford University, where they put a linear accelerator on the robot. A robot equipped with artificial intelligence which predicts the movement during the breeding, during the peristalsis of the tumor, and so that irradiation is absolutely to the 10th of the millimeter. So there is no way that healthy tissue will be damaged, only the tumor tissue. These are some of the great radiologists working there. This is ICG. This is one of my colleague surgeons. This is again this OR. There is two of those. This is a treatment of the prostate which is absolutely superior to any kind of surgical treatment. It's, again, for us surgeons, urologists, hard to say, but this is 96% of efficiency without knife, without pain, without risk. And of course with preservation, with all the functions. This is my colleague Leonardo Patrelj, who was the founder of the liver transplantation program in Croatia. Now he works only in this hospital, still very young. So not to prolong this too much with this film, just some thoughts which will bring us in our theme for today. So modern surgery from barber shop from today starts with introducing new technologies, of course, techniques. The key point is for forming of multidisciplinary teams. So there is no individual decision today. There is no way that this patient is mine because I'm a genius. There is no eminence-based medicine. There is only evidence-based medicine. So teams bring decision together with all the algorithms and all scientific facts they have about the patients very individually. So everything changed with introduction of surgical oncology, with combination with all kinds of neoadjuvant, adjuvant treatment, and many tactics. What is hybrid surgery? Also new, let's say, name. This is something where we acknowledge that there is no, unfortunately, surgery is not most powerful and the best and the only. So we have to admit that a lot of other disciplines and the ways and modality of treatments only can help to the treatment of this particular patient. So to minimize surgical trauma, we combine many other approaches. Like in these scenarios, when everything is possible in order to kill a tumor, so we can combine operation with stereotactic ablation radiotherapy, which SABR, or to only to irradiate tumors, just to follow them up, or to irradiate surgical bed after the surgery, or any kind of technique. So, what is radiosurgery? Is it replacement for classical surgery, or something that can be combined with classical surgery? So, of course, it's the other thing. There is something else that we have noticed in the last 5 or 6 years. Of course, this radiosurgery is not performed only in this hospital, but throughout the world. And that is Abscopal Effect. Very interesting for you oncologists that we have noticed that tumors are more vulnerable to the chemotherapy after the radiosurgery of only one part of the organ or one part of the system. Why is that? We believe that that's because of the releasing of many tumor molecules and particles which immunomodulate the reaction to the chemotherapy. So there is a synergy with radiosurgery. Technically, what we did in the last 50 years was not only to improve the preciseness. For example, in last, let's say, this blue, you will see that integration, better beam shaping, which is more precision, and aiming, of course, more precision. And that allows us to deliver much higher doses of ablative doses of radiotherapy, which was not possible during fractioned classical radiotherapy. So, one to another, radiation therapy, radiosurgery. Radiation therapy, classical follows surgery. radiosurgery in most of the cases, in many of the cases, replaces surgery. Unfortunately, radiation therapy treats also and damages also the healthy tissue surrounding the tumor, but the radiosurgery is sub-millimeter precise, and there is no way that it's going to damage any of the healthy tissue. Classical therapy requires multiple treatments, and the radiosurgery 1 or 2, not much more than 5 treatments. Of course, you need diagnostic equipment. Of course, you need something like that. This is very an age. Its price was like 3 million euros, I guess, at that time. This is very important. How to aim. This is the system developed with Varian Age. When they put the system called optical surface monitoring system, which monitors 10 times in a second all the points of our body in 3 dimensions in 20,000 dots, 20,000 points. So there is no way that patient can move when you irradiate certain parts, and the radiation continues. No, machine automatically stops because and waits till the tumor comes back into the position. So this is the great, but not the best. The best is something that I'm going to show you. But that's it. This is from the literature, and this is all the let's say fields and applications that are performed in this radiosurgery hospital, from the brain, from the bones, lungs, pancreas, liver, ovarian, melanoma, colorectal, and adrenal glands. You just name it. Point is that it has to be very well indicated. What would I like to say? We, in radiosurgery, every day we spend 2 hours during the MDT for only 10 patients. 2 hours discussing every aspect of that patient, every findings. And at the end, less than 10% of the patients end radiosurgery treatment. Because if patients has 150 metastases, lungs, let's say, prostate primarily, lungs, bones, whatever, there is no way that with this treatment that you are going to heal him or her or cure. So if there is no chance of cure, we are not going to do it. So it's very efficient, but you have to be very wise when you decide which patient is suitable for that. So this is so far then 4,000 procedures that we performed, and these are regions mostly attacked: lungs, liver, pancreas, brain, and I will show you some examples. What about lungs? It's not experimental medicine. I'm not selling you magic. This is something that entered, of course, the literature. You know that Sabiston is like a holy book to all our surgeons, and this is from their thoracic surgery chapter. The stereotactic radiosurgery is, of course, already established technique. So this is how to prepare patient for radiosurgery, to do a 3D reconstruction, to do the planning, and this is something from how some bizarre reason our guys who were preparing this presentation, they put this in this direction. So you will see this is the beginning of this tumor, and this is at the end what's left of this tumor. There are, of course, dates that you can check. This is another example. After 3 months after radiosurgery, the volume of the tumor reduced, as you see. This is an example with 2 metastases. It's very well defined. Our physicists define not only the volume of the tumor and the borderline of the tumor, and also the peritumoral surrounding tissue, which is also as a layer, as a coat, is also irradiated with a smaller dose. So it's already very, very precisely planned. It is possible to do 6 liver metastases at the same time. Another example, huge tumor. Can you imagine patients with that kind of tumor? Of course, you would operate. But what about he's 75 years old with chronic obstructive disease, with pacemaker? What would you do? You would is there any efficient way that chemotherapy can cure him? No. So this is the problem, and this is the whole new field, new philosophy. How can be treated? 6 months follow-up, tumor. The top left was the rest. So this is it. Also huge tumor, you see on the upper right, and the ends on the lower left. PET-CT shows no activity, although there is a tumor still standing on the CT, but PET-CT said no, there is no activity. 7 months follow-up, also tumor. See that? 1, 2, 3. 7 months, tumor volume regression 46%. So overall, for lungs, primary, secondary tumors, reaction to this therapy is 96. So we have good local control of disease. Is it cure? Let's not be that brave. Maybe we'll see about that combined with other modalities, but it's regression. Okay, pancreas. We're doing 25 to 35 pancreas cancers every radical surgery. I don't count that exploration, so whatever. And it's very, let's say, frustrating surgery. Because whatever you do, you end up on the world statistics, so that's only 5% and less of the cured. So what are you doing? You're doing surgery which lasts for 4, 5, 6, 7 hours with huge possibility for complications. And what did you do? I'm not sure. So this is something we expected very impatiently from chemotherapy, from all the other modalities, and I believe that even now, we have the not complete solution, but very powerful tool to help us. So what was the overall survival of unresected patients? That is response rate. So this is months, 6 months, 7 months, 6 months, 7 months. So if you don't operate, no matter what kind of the regimen of chemotherapy you will apply, they live not longer than 7 months. This is a statistics from radiosurgery. Total 33 cases, till 2011 now there are slightly more. What is the goal? To deliver ablative dose precisely into the tumor and to save this is called sensitive adjacent tissues. So duodenum, stomach, large vessels, we don't want it to be near radiation. You who work with the radiation, you know that it's very vulnerable even from classic radiation with smaller doses. In order to save surrounding tissues and how to be more precise, they developed GPS navigators. They are called Calypso Trackers. So it can be placed under the CT percutaneously, or there is a scenario which I did in many occasions when open patient and see that there is no way that I can radically resect it, curably resect it. So I do bypass and I put inside tumor from 3 different positions. It's like a rice size, rice bean size, very small. You can put it inside of the tumor, and it emits all the time. So when they do the radiation, you have to respect that pancreas is moving. It's moving organ. I was also surprised during breathing and during the peristalsis. It moves like 1.5 centimeters in all directions. So you cannot precisely irradiate it unless you have guidance, and this is guidance. So Calypso. And this is the one example of percutaneous placing the Calypsos. And ablation is now planned around those, because they give orientation in 3 dimensions. So the the aiming is much more precise. Of course, this is the technique that should be performed during the time when patient is not breathing. So this is breath hold technique. It's mandatory. So if he moves, then machine recognizes it and stops irradiation immediately. That's the advantage. So these are some examples before and after. This is some pictures from the planning, and this is also example before and after, before and after. Is also July, October, November. So in 4 months, you see reaction from this size to something like that. This is also follow-up of 12 months, and you see that tumor has shrinked to 4 cubic centimeters. This is also one example of tumor, which reduces also. So local control for patients with 1 year follow-up is like this. What changed this? This changed complete picture of cancer treatment in Croatia. So this is the evidence. This is the estimated incidence by country in Europe. This is Europe. This is Croatia. So by incidence, we are like inside. But by mortality, you are well below that average grade in Europe. And when you count also the incidence mortality ratio, we are also very well below or behind. So people are less dying from pancreatic cancer in Croatia. Why? Why is that? How did that happen? This is the idea. This is the median of total survival in a different, let's say, series, and this is radiosurgery, 25 months median. And this is the, sorry, this is it. This is number of the patients irradiated by radiosurgery in radiosurgery, and this is the survival, median survival in Croatia. So we made a difference. It's small number of patients, it's short period, but we made a difference. There is something in that. Also, the other holy book in hepatobiliary surgery is giving us stereotactic ablation radiotherapy as a tool which can excellent local control and minimal toxicity. This is how it reacts on therapy, local therapy after this. These are overall survival of the patient. So we are not going to cure someone who has advanced disease and metastasis in different regions of the body, but we can very powerfully control locally. So also this is the matter of sense, who to treat and who to not to treat. These are colorectal, breast, lung, pancreas at the top, and this is local control of the same. So basically it's worth for all the tumors, all the secondary tumors. This is in our experience, how locally tumors inside the liver react to the radiosurgery. 94% of them regression. Of course, there are some of them that with progression, but it's only 5%. Let's go on. Some of the pictures, planning, and this is also part of our radiology preparation of the surgery, of the resection, and it can show that some of the tumors 1, 2, 3. But this is the technique. I'm not sure, Bujar, how do you do it in here? This is the fusion technique between MRI and CT, and this is how it looks like at the end. So it gives us a new quality for that. This is the example of preparation of the treatment, and this is the treatment before and after radiosurgery. One application that takes 15 minutes with no anesthesia, no anything. And patients, it's outpatient procedure. Patients are not staying in the hospital. The other extra hepatic tumor, huge one, which reduced also. Difference May, November, tumor, no tumor, tumor, no tumor. This is something that also came up during that developing of technique with Siemens. This is technique, it's called diffuse waiting fusion, telling us during MRI how cells react and how many cells are viable inside that area that you treat. So red are viable cells, there are no viable cells. So sometimes you see the remnant of the tumor, but it's not viable anymore. It only takes it to follow up. So complete resection, complete regression, disappearance of liver mets are in our series 38% and 96% are regression. These are outcomes of many centers performing SBRT. So I will not keep you on liver anymore. So you get the idea what is the liver. Prostate, also delivery plan. Also, it's in the Calypso's navigators are stuck in through the rectal ultrasound approach, fusion technique, and how to do it. Prostate also moves a lot in different directions, so the Calypso is very important. Read this, 90% are cured with this. So why would we operate anyone? Open surgery, open urological procedure for prostate means complications, bleeding, 60% of impotence. I know what's the percentage of the urinary incontinence. If you do it laparoscopically, of course it reduces. If you robotically, it reduces, but you still have complications. And this is cured without knife. So what are we going to do about the prostate? I'm not sure. Brain. Of course, irradiation of the brain, stereotactical radiation of the brain exists already. Gamma knife is very powerful, but this is much more precise, with much more higher doses and much more convenient and comfortable for the patient. These are examples of the metastasis of the brain. Same here. And the patient is not stuck with that, you know. Do you know how the gamma knife is placed with fixation of the skull? This is only mask that's put on just to hold a little bit patient in that position. So a few cases. Sigmoid cancer, liver and lung metastasis, operated Hartmann, and this is the histological exam, T3 and 2, M1, and MDT decided first chemotherapy, and after that PET-CT, which found, of course, mets in the liver and the lungs, and then we decided to do SBRT. So let's go back a little bit. That's May 2019. Then 2 months after that, we did SBRT of the lungs, and after that, SBRT of the liver. What is left? That's this area of the liver is still very suspicious about mets, so we decided to operate on that, and we did. So we found that that 5 and 6 segment and also 2, that we found it was reduced but still viable tumor, but that irradiated in segment 2 was dead already. So second case, rectal cancer to T3 and to M1, metastasis in liver and lungs, radiosurgery, both liver and lungs, and vertebra. I think it's somewhere like that, somewhere around the spine. So a year after that, everything was, and also there was a classical irradiation of the rectal cancer. So it's cured. Rectal cancer was found absolutely on biopsy without a tumor, and the follow-up of the lungs and the liver were steady. So we have a patient who is maybe cured without surgery. Lungs with bone metastasis, also irradiated. As you see, it is possible. These are some institutions that collaborate with radiochirurgia. I will give you also an example of professionalism of this team. That Varian Edge machine, which is very expensive, very powerful, is under surveillance of the Swiss team who is in charge of the Europe. So each and every irradiation plan has to go to approval to Switzerland, and after that is only performed in this hospital. So this is it. I will give you now, and it won't take long, one example of how we do it today. And this is the model, I think, that complete our oncological medicine is going to go in this direction. So how we do it? Lady, 57 years old, with terrible diagnosis. Cholangiocellular carcinoma, which is inoperable. So what would we do yesterday? No, nothing. Nothing. There is no way that you can give her efficient chemotherapy, no irradiation, and there is no way that you can operate it. So it was proven to be cholangiocellular. It's 13 times 9 centimeters in size and placed in the middle of the liver. So how can you do it? It's impossible. But the team who is consisted of those guys, decide this algorithm. So it's individually tailored for this patient. First, chemo embolization of the tumor in order to reduce the tumor, to reduce viability of the tumor. After that, percutaneous embolization of that right branch of portal vein in order to stimulate the hypertrophy and hyperplasia of the left lobe, which would allow us to give us more chance for radical resection. After that, SBRT of the edge of the tumor, sterilizing because you will see that some of the satellite tumors are already around this primary, and only after that, surgery. So, first of all, systemic chemotherapy. After that, in April, transfemorally selective catheterization of the branches of the right hepatic. The guy who does it is great and perfect top radiologist, interventional radiologist, who put some gel foam with whatever. 2 months after that, percutaneous embolization of right portal vein. After that, what happened? The tumor reduced. There are no secondary changes in other parts, predictably healthy parts of the liver. And it ended after 2 months with decent hypertrophy of the left liver. So if you remember, this was before, and this is after that. You see the hypertrophy of the left liver. Still very, very scary when you look at it. After PVE. After that, SBRT, because we wanted to clean parts surrounding the tumor, which contains usually, and in this case, proven satellite tumors around that tumor. And it was what was applied, 45 grays. You who do radiotherapy, you know how it's impossible to deliver 45 grays precisely inside of any kind of tissue, especially not in 3 doses. this is the way how to plan it, how to do it. This is preparation for SBRT. What happened? Partial regression of primary tumor, hypertrophy of the left lobe, 40% of the actual volume. Before that, it was only 27. There are no secondary changes during that follow-up. And this is the plan how to prepare a plan for resection. And after that, also the vascularization of the liver is also, of course, respected. And what we did is extended right hepatectomy. Of course, with 4A-B segment, you know how whole liver rests on only 2 and 3 segments, and maybe part of one, which is originally 20% of the volume. After the PV, it ends like 40%, which is compatible with the survival. All the techniques are performed. Tumor mass was almost 1 kilo. So this is the technique. During that, we also apply ICG in the cyan and green in order to see the areas that are very well vascularized. And this is how it ends. This is control MSCT. Patient was discharged on day 14. So I would like to stop now. I have full stick of cases. If you are interested, I will be glad to leave it to check it up again. But probably I would repeat myself. What I wanted to say, there is new horizon, there is new perspective. And although I'm not very happy that surgery is losing field, I think this is the great thing and great news for our oncological patients. We had now patients that were lost, bound to die very soon, and we have patients that with inoperable, incurable disease live for 2, 3, or 4 years. And one doesn't exclude another. There is good opportunity to combine different kind of treatments, even to expand surgical indications, because something that we were not willing to operate before, of course, which was justified. Now we have a chance to operate it later. So I think this is a good story and do good information for all, of course, you who are opinion makers or opinion leaders here in Pristina, and to give to your patients, because we are, of course, always open to cooperation, to discussion, to friendship. Whatever you say, we are here. So thank you so much for coming here.
Thank you, Professor Zovak, that you came to Kosovo with opportunities to cooperate and continue what you were doing before. And thank you that on our request, you presented something new to update or to inform our colleagues of surgery, oncology, and radiology about the opportunities coming. And now, any questions, any discussion? Open.
Professor Zovak, thank you very much for your outstanding lecture. It was really nice to hear new things that in the neighborhood you are applying. Hopefully we will do with our colleagues in the future. We are all interested to restart maybe cooperation with Zagreb University, with our University of Pristina here. And I would like to ask you about the pancreas, that also you are using this radiotherapy. How, in the follow-up, how many months did you win after this therapy? Because we know that it's very sad story about the pancreatic cancer. Thank you very much.
When I was a very young surgeon, I bought in Paris a book about pancreatic cancer surgery, and the preface was written by, I don't know what surgeon was that. It said, it took me 12 years to get disappointed in pancreatic cancer surgery. So that's what is real. There is seldom, very rare cases that you can cure it by yourself. There are 2 scenarios. One, operative surgery possible, operatively, possibly radically, 2 centimeters, no lymph node involved, no vascular involvement, okay, I will do Whipple. But 6 months ago, I was in Heidelberg, which is the European Center for Pancreatic Cancer Surgery, and asked their boss, their guru, what if would we radiosurgery treat all the cancers, no matter they're operable or not, before the surgery? What will we get? We don't know yet. Maybe some of them will be cured and operated for no reason after that. Maybe that would be good story, good information. But maybe some of them, and we are doing it now, some of them would shrink and, let's say, not in release that, let's say, superior mesenteric vein or artery, and then we will get chance to operate it. This is the idea. But so far, I didn't get not one case. The reason is that people who get very good result after radiosurgery, being inoperable cancer, feel well. They are told that their tumor shrunk, so they are not very motivated for radical surgery. So this is something that we will have to think about in the future. This is that scenario. The other scenario is that we still don't know what would happen if we would do Whipple and do intraoperative radiotherapy. We didn't do it yet. We have machine. We can do it. You know that in pancreatic cancer surgery, the greatest problem is retroperitoneal part. It's called mesopancreas. It's very complicated, very deep inside, and 90% of the surgeons do not do that radically. What if we could apply huge amount of radiation into the surgical bed after the surgery? We will see. But there is a way, there is a, let's say, future that is promising. And there is a huge job to do. Yeah.
Okay, thank you very much again. I ask my colleagues if they have questions, especially from oncology, because we are interested so much in hearing this kind of radiation. We know about that, but we cannot use it. And about pancreatic cancer, really we in Kosovo do only chemotherapy because all of the cases are in the advanced stage, maybe in third or fourth stage, and we do only chemo and then follow up them. So the prognosis is very poor. They lived for 6 or 7 months. My question is, how many patients do you have there and what kind of results? I think from they are not operable and you treat it with stereotaxic, for example. Yeah. What is the number of?
Number of patients I showed you till 2019, 43%. Now there are some around 60%, and the median survival of inoperable, not resectable, is 25 months.
That's huge.
That's from 7 months to 25.
Yes.
Regarding chemotherapy, we were very anxious to get new therapy. I remember times where Gemzar was introduced. We were very happy about that.
Same still.
After that, FOLFIRINOX is very promising.
Same.
We know that.
Yeah.
But you have to give systemic therapy. With all, FOLFIRINOX is not very well accepted
so
by
toxic,
many patients. Too many side effects.
Yeah.
So if FOLFIRINOX can be combined with this, why wouldn't we do it?
Yeah.
So we'll see. This is something that we have to create.
Yeah. But when we don't have this kind of techniques to use it, that is a very big problem.
It is a big problem because I know that our radiotherapists also treat with classical radiotherapy pancreases, but results are not good.
Yeah.
And side effects are also very complicated. Because there is no way that you can miss duodenum when you irradiate head of the pancreas, unless you have this tool.
Yeah, and in Kosovo here these days, I think it's a big problem with the pancreatic cancer because during the years the number are increased. Maybe we saw year by year 40 to 50 patients. They are young patients. They are suffering from pancreatic cancer. It is very, very complicated, and they live very short.
Well,
thanks.
This is something that we should seriously consider. Unfortunately, this is business. This cyber knife I told you about, it's being operative in December. the cost of the machine is 10 million euros. So there is no way that public hospital in Croatia is going to buy this, because in 5 years that machine is going to be old machine, because something new is going to emerge. So it's very complicated, but now you have a machine that can cure very precisely each and every metastasis on the lungs and prostate with 96% of the efficiency. What can you do? And, sorry, I have my colleague, younger colleague, yesterday, the day before yesterday, came to me with a CT scan of the lady who was recently operated on colon cancer with one metastasis in the right liver lobe, between, let's say, medial and right vein, which gives us only a mandatory task to do right hepatectomy. So you will do right hepatectomy of the organ, which is huge, because of this one metastasis. And I told her, you are not going to do it. You have to give information to the patient. So she has to decide. Give her. So if radiosurgery, by the way, in Croatia, it's covered by insurance for malignant diseases. It's not paid. If that patient has a choice to do it with or without surgery, she has to decide. You are not. You have no right to give your opinion and to impose to her.
Thank you, Professor.
Also, other solutions for common radiofrequency, it's just one or two. Do you have those tools in your private hospital?
Yes, there is radio frequency, but there is no way that we are going to use it. In only one scenario, and that is hybrid surgery during the open surgery. Because if you have tool to do it without percutaneous, you know, Bujar knows how complicated it is to put a needle inside of the liver tumor percutaneously, and you know that radiofrequency and umbrella, how to spread it, and what's the size of that necrosis you're going to perform. It's very complicated. We do it sometimes with radiofrequency or microwave, but only during open surgery. Percutaneously, no. We do it.
We are doing. We are not doing there, but you mentioned.
We are doing, but very rarely.
For example, Heidelberg, also nearby, it's Mannheim University. We had before a very good cooperation, and actually I was in that team that they had done. Because the radio frequency doesn't matter maybe 2 or 3 how many of these states. But we don't have that. That's such a good machines as also.
We will have that soon. Actually, we have the machines, but we need to sit and discuss it. But I have a difficult situation now because we are having excellent expert like Professor Zovak, whom everybody wants, and Dean. We have to be a Dean in 4 minutes. So I would like to thank Professor for answering the questions, for you making the questions.
Thank you so much.
And we do certainly hope to have Professor again in Kosovo.
As a last word, I believe that these two countries should cooperate more. And I think we are two very newborn countries, and that we have to cooperate. And it's not easy. It's not very hard to cooperate, and it's not a big frustration to be a small country, because you don't have to repeat mistakes that someone already did. So we have to choose. Center of excellence, as you said, Mannheim, whatever, mine is Tel Aviv, and there are guys that know everything, and they will help us, and we will help each other. So this is the idea. I will give you also my card, my email, whatever you want to ask. And really, last sentence, you are all invited to visit radiosurgery hospital in Sveta Nedelja near Zagreb. I will be more than happy to be your guide. You will talk to your colleagues surgeons, you will talk to your colleague oncologist, you will see how this radiology is performed. The best thing, not to hear from me, but to see by yourself. Okay? Thank you.